How to Become a Psychiatry Jedi, Part 2. This is a review from our last presentation, but I like it, so I will review it. There was a 2006 study that showed that the most interpersonally effective third of prescribers of psychiatric medication achieved better outcomes with placebos than the least interpersonally effective third of prescribers got with active antidepressant medication. So in this presentation, we're talking about what is that special sauce that these most effective third of prescribers have. The nuanced and complex things that we provide as psychiatrists more than just the chemicals we prescribe. Before I get into how we're addressing treatment resistance and how we're encouraging patients to take medication who are resistant to take medication, I do want to validate that patients have real reasons for mistrusting psychiatric treatment. There's real horrors in our history. Historically, conversion therapy, asylums, and the so-called schizophrenogenic mothers. Yes, in the past, psychiatric lore that now, but then it was psychiatric reality, was that we thought that people with schizophrenia were that way because their mothers raised them and they had cold mothers. They also thought that autism was caused by emotionally cold or distant mothering. So there's some blaming attitude of psychodynamics in our past. The media is not helping us whatsoever. And there are entire religious cults like Scientology devoted to being anti-psychiatry. It makes it feel kind of unfair as psychiatrists, honestly, that you don't go to your endocrinologist and tell them, well, I mean, do you really believe in insulin? Or see a cardiologist and say, I don't believe in stents, so I must not have a heart problem. Or I don't believe in melanoma, so I must not have it, to their dermatologist. But these are the things that we get all the time in psychiatry, that this stuff isn't real. And thus, it can be tempting to kind of emphasize that biological explanation for psychiatric medication treatment and leave it at that, to legitimize our medications in response to society's ongoing demonization of psychiatry, and say, hey, taking psychiatric medication is just like taking medicine for diabetes, except it's not. There's a lot more that goes into it psychologically. Now, it's helpful to explore the cognitive dissonance between a patient's attitude towards psychiatric medication and their attitude towards medication for a different health issue. But we want to be cautious about this biological oversimplification, so to speak. For example, in this 2014 study, college students seeking treatment for depression were administered, this was a fooling people study, a DNA test that they were told would determine whether their depression was biological or psychological in origin. So the college students who were led to believe that their depression was strictly biological in origin, a chemical imbalance, had worse perceived prognosis. They did not have any improvement in self-blame or shame compared to the group who were told that their depression was psychological in origin. And they had a lower expectancy that psychotherapy and medications would help them. So, whoops. Okay. A strictly biological, I say strictly biological label of psychiatric illness can assuage some patients' guilt and felt sense of responsibility, but further their sense of victimhood and helplessness. Expectations matter too. In a 2021 study, 27 participants with anxiety disorders were all given escitalopram, that's Lexapro, at the same dosage, 20 milligrams. Again, these people were being deceived, but this time they were deceived because some of them were told that they were not getting medicine, but they were getting a neurokinin 1 receptor antagonist that would give them the same side effects, but no benefit of medicine. And some were told they were getting the Lexapro medicine. So some people believed they were getting a side effect pill, and some people believed they were getting active medication, but they all got the active medication. And of course, right, the patients who expected they were going to benefit versus the patients who expected they were going to be harmed with side effects did significantly different, even though they all received the same medication at the same dosage. And psychotherapist allies with us psychiatrists can be pivotal in setting up these expectations of medication. I think it was very interesting. They followed this up with PET scans. So on PET scans, serotonin transporter occupancy was the same in both groups. Those who were told they were getting a side effect pill and those who were told they were getting active medication. But in the groups who were being told they were getting active medication, who expected benefit, dopamine transporter binding was decreased in certain areas, and a decrease in binding actually means there's more dopamine because the dopamine transporters are more filled up. So basically, there's more dopamine in the areas of the brain in the people, and in the putamen and the pallidum in the people who expected benefit from medication. Whereas the people who expected side effects had decreased dopamine in these same areas. So if you think about this, if I'm prescribing my patient Lexapro, and I'm telling my patient it's going to be really helpful, I have a good relationship with that patient, I'm setting up this positive expectation. The pill may be increasing serotonin transporter occupancy, whereas the positive expectation I set up is increasing dopamine in the putamen and pallidum. There's this is sort of like a neurochemical correlate of positive expectations of a medicine that is not mediated by the chemicals itself, but is mediated by the relationship with the psychiatrist.
You just have a chemical imbalance.
Thus, we should resist the pull of biological reductionism, that is, reducing all of the effect of our medicine to the chemicals within the medicine, leaving out the relationship with the prescriber. A Jedi of psychiatry truly embraces the ambiguity of two truths. In DBT therapy, we call this a dialectic, okay? On one side, right, there's this idea, meds are just a band-aid. Changing your thinking in psychotherapy is the only way to actually get better. That's Darth Maul. And then on the other side, Emperor Palpatine. Medications are the answer to treating your symptoms, which are caused by defective neurochemistry. And in a way, both are kind of true. That your symptoms are determined by your neurochemistry and your power and self-agency and your relationship with your psychiatrist are pivotal in relieving your symptoms. So it's both rather than one or the other. That our medications are both biologically active and our relationship is active in how the medications work and affect people, and the patient is active in this treatment process. So we're kind of balancing we want to avoid a blaming attitude of psychodynamics, and while still empowering patients that their relationships, their lifestyle choices, their thoughts impact their mental health. and avoid the disempowering attitude. If it's all biology, it's all chemistry, we're just going to balance out your chemicals, there's nothing you have to do about it, right? We're also kind of balancing out the individual's belief in the power of medicine to heal them and their belief in the power they have to heal themselves. I'm reviewing this slide from last time. It is a review because it was in the previous presentation, but I like it. That medication can be both essential for change and the patient still be responsible for the change. So I use the analogy of being stuck at the bottom of a lake with the weight on your ankle. And the illness is the weight. So you need the medication is an essential piece of this equation, kind of cutting away, relieving the weight. And yet the patient still is responsible for swimming to the surface. That's their work, their psychotherapy, they're getting into a healthier romantic relationship, the regular sleep, the good nutrition, et cetera, that go with achievement of health. As only a Sith deals in absolutes. Anakin is going to the dark side when he tells us that he is 100% sure of your diagnosis and how these medications work on the body. It's tempting to give in to biological reductionism. Why is this so tempting? Well, patients are tempted to embrace the strictly chemical imbalance explanation for illness because then the badness is located in the chemicals and instead of themselves. Also, this may excuse them from making lifestyle changes, going to therapy and addressing their unhealthy interpersonal relationships. And then clinicians may be tempted to offer this strictly biological explanation as part of our empathic pull to relieve a patient of self-loathing and shame. Psychiatrists may be very tempted to focus on biochemical explanations as we talk to patients about medication to assert our legitimacy and usefulness as prescribers of biological treatments, that we know what we're doing, so to speak. And it's interesting because I remember when I did this presentation before for the Florida Psychological Association, and I really enjoyed it, and I got a lot of good questions. But one question I got, it was an anonymous question in the chat.
You just have a...
Sorry. It was an anonymous question in the chat, and it was, so why even do psychiatry if you don't know why how these medications act on the brain? Which, right, translated to, what are you doing, psychiatrist, if you don't know exactly how these chemicals act on the brain? You must not know what you're doing. And unfortunately, if I sat around and waited until I knew exactly how my medicines worked for exactly which patients, I would be at home in my pajamas and not go to work to practice psychiatry. It is impossible to practice medicine without making peace with a lot of ambiguity and unknown.
You just have a deficiency of serotonin, and SSRIs increase the level of serotonin in your brain.
So resist the pull of the delusion of precision. Remain curious.
The moment you feel confident you have the answer, that is when you know that lost you are.
So what do we talk about with our patients when we talk about medications if we're not talking about chemicals, right? And I want to make a point here that staying abreast of the nuances of psychopharmacology is pivotal in our role as psychiatrists. That in your personal time, it's awesome that you're extremely curious about chemicals. But when you're in front of the patient and a patient asks you, well, doctor, how exactly does this medication act on my brain? It may be comfortable for us as a doctor to start talking about chemicals, but that's the time to think about meaning and what that question really means. So when a patient is asking you, how exactly do these medicines act on my brain, doctor? Are they really asking or saying, I'm feeling very scared and vulnerable. I'm attempting to gain some semblance of control in a vulnerable situation by trying to understand the pharmacology to make sure this medicine isn't going to hurt my brain. And be curious about that. Address that for the patient. So definitely patients fear medication, and with good reason. They fear dependency. They fear loss of control. They fear loss of identity. And they wonder what taking psychiatric medication says about them. Are they weak or deficient? Does it confirm badness or deficit? Get curious about what your patient's family of origin thinks about psychiatric medication. If your patient tells you, oh my goodness, my grandmother was institutionalized and she told me that the meds made her never write again, that's definitely going to impact how your patient is going to experience medication treatment. Are there certain spiritual or religious beliefs about medication or mental illness? And don't forget to end with hope. I think that we spend so much time with the patient discussing side effects and they're wondering about that sometimes I even don't realize till the end of my psychiatric interview that I forgot to tell them the expected benefit of the medicine, to let them imagine 6 months from now, I gave you the perfect medicine. What do you like on it? And include the patient's role in effective treatment. So now we're going to explore how to address resistance to taking medication. First, addressing fear of being controlled by medicine. As patients fear of being harmed, and especially patients with a past history of being harmed by authority figures and caregivers, will fear being harmed by psychiatric medication. Patients with a tenuous sense of self fear that medication will alter who they are as a person and fear losing their identity.
The power within you to make yourself better, we will reveal together.
Focusing medication discussions on empowerment of the patient and cultivating an internal locus of control will provide a better treatment response. So emphasizing what patients can do to make their medicine work better. Also, and coaching them to pay attention to how they feel and assertively communicate that to their psychiatrists. I think psychotherapists can help us with this a lot. So here's how Qui-Gon Jinn, Jedi psychiatrist, is empowering. He tells his patient, on stimulant medication, Obi-Wan, you have more freedom to choose what you focus on and what you tune out, which is a different narrative and a different language than stimulants are going to make you focus. And then our Jedi psychiatrist, Luke Skywalker, unencumbered by your depression, our goal is for you to be your most authentic self on sertraline. That's a different narrative than, well, Zoloft will improve your mood and make you feel better. He's using language that promotes identity, authentic self, and promotes self-agency, being unencumbered. and choice. That's how we address fear of being controlled by a medicine. Patients are going to view their psychiatrist through the lens of their childhood attachment figures. And we can actually help patients anticipate these reenactments of childhood traumas and the negative power and control struggles that patients can get into. This is how Mace Windu does it. So when you were on meds for ADHD as a child, you had no say in your treatment, and medication symbolized your badness as a kid. So it makes complete sense that you're scared to start medication again. Sometimes, with me as your psychiatrist too, you're going to feel like I'm trying to control or punish you, like your mom did. When that happens, please let me know so we can work through it together. Those bad experiences with medicine in the past will make side effects to your new medicine magnified for you, like on a loudspeaker. Remember that you can stop the medicine at any time. I just ask that you call me and we make the decision together. So he's setting his patient up to anticipate that they are going to want to stop the medicine, that they're going to have side effects on the medicine, that they're going to kind of feel like they're punished or being controlled, and inviting them to tell him when that happens so they can address it, to bring it into the room. Obi-Wan emphasizes, I'm not here to tell you what to do. I'm here to give you information to help you make a decision about medicine that is driven by your values and medical evidence rather than fear. Let's talk about patients stopping medication without talking to us. And for some reason, this always comes up at the very end of the appointment, the 30-minute appointment. Oh, by the way, doctor, I stopped taking my medicine. Like, why didn't you lead with that, right? So we finally get our patient to start a new medicine and they stop it. We need to keep in mind that medications are powerful symbols of illness. And patients often hope that they can rid themselves of illness by ridding themselves of the need for medication. Patients may take too much or too little medication or start and stop it on a whim just to feel like they have some semblance of control. How do we address this? Well, some non-judgmental curiosity is nice. I actually use the phrase, let's be curious together about a lot. Like, let's be curious together about ... insert whatever treatment interfering behavior your patient is engaging in du jour. So Obi-Wan says, let's be curious together, Anakin, about what's going on when you stop your medicine without talking to me. Anakin says, I want to be strong enough to do it on my own. All right. So you kind of have a sense of what's going on with him. Obi-Wan validates this. It's important for you to be self-sufficient. Your father was never there for you. How can we make it easier for you to reach out to me? He's recognizing how these authority figures in Anakin's past are playing into his relationship now and ability to make good use of his medication.
Choice of illness, you have not. Choice to either face illness and take medication, or deny and hide, you have.
I also like to point out to patients that their choice lies in whether or not they face their illness with treatment, not whether or not they have the illness. They can't rid themselves of illness by ridding themselves of a medication, unfortunately, as our wise Yoda tells us. We're going to go over in the next section a lot about how understanding developmental history is key to understanding a patient's relationship with their medical authority figures. All right, so different attachment styles. And of course, guys, this isn't clear cut. These are some examples, right? But neglected, avoidant, or dismissing. Give me 1 second. My dog is eating something. back to presentation, naughty dog. So patients with avoidant attachment styles, often they were neglected. They were not given the caretaking. They fear being dependent on a medicine, as they could not depend or rely on their early caregivers. They're often eager to debate with the doctor to maintain that they are in charge and the doctor is not in charge of them. They're prone to change dosage of medication or stop medication without talking to their doctor. Sometimes they may experience an increasing the dose of their medicine as a controlling or punitive move on the doctor's part. And they also tend to be kind of like one strike and you're out kind of patients. Like, you know, this medicine didn't work for me, so no meds don't work for me. Then anxious, preoccupied attachment style patients. They really fear loss, being left by a caregiver. They may be outwardly acquiescent, very complimentary of the doctor, but covertly subversive of the treatment, forgetting their medicine. They may resist becoming well because that might mean losing the cherished and predictable source of caregiving from their doctor. And sometimes medicines themselves can become attachment objects, and the process of tapering a patient off of a medicine can be more harrowing than getting them on it. They may be afraid to disagree with the doctor or give the doctor honest feedback. Like when the doctor asks, "Hey, how are you doing on the medication?" "I don't know, doctor, you tell me." Then disorganized attachment style. So this is common in patients who've been abused by caregivers. They expect harm. So they're prone to nocebo responses. The nocebo response is when a patient experiences side effects to a placebo. They expect side effects and they experience side effects. And those are real side effects that they're experiencing. As we talked about before, there's a real chemical correlate to them. They tend to not trust their doctor. They may view medication treatment as an intrusion on their body or in some ways a reenactment of physical or sexual abuse. I was reading this book by David Mintz the whole time I was making this presentation. So you're going to notice that I quote Dr. David Mintz a lot, and this is literally a page out of his book. So those of you who really want to take a deeper dive into this, I strongly recommend Psychodynamics, Psychopharmacology, Caring for the Treatment-Resistant Patient. How do we address nocebo effect? It can be such a pain for us, right? Side effect after side effect. Dr. Mintz says, it is as if these patients, unable to say no with their voices, do so instead with their bodies and their side effects. First, encourage the patient to disagree with you openly. Talk to them about how this really helps you understand them better. Welcome dissent. We want their frustrations, their fears, their sense of betrayal. We want it out on the table so we can address it together. Emphasize that they can discontinue the medicine at any time. I tell my patients, I use the expression, you're just dating the medicine, you're not marrying it. So you give them an out, a safe out. Many patients may need to experience failing or having side effects to a few different medications in a row before they trust that the doctor actually is going to listen to them and let them stop medications, before they can feel that security. So part of the process may be failing medicine after medicine and listening to these people. And then explore the treatment interfering meanings that patients hold for medication. Are they concerned that it's confirming that they have a deficit within them? Are they experiencing you as similar to their caregiver in the past? Individuals from socially disadvantaged groups, minorities, women, low socioeconomic status, are actually more prone to nocebo effect. We actually find in studies that these disempowered and disenfranchised populations have a higher risk of nocebo response, which makes sense. So let the Wookiee win. The more power the patient perceives themselves to have, the better. Remember that the patient is the hero here, not the doctor, ultimately. So even when the patient has a positive treatment response, right? The medicine went great. And we're like, yay, I found a great medicine, finally, good me. Okay, celebrate internally, but give the patient credit for the win. And ironically, the more credit you give the patient for like, wow, you made really great use of this treatment, you started a regular sleep schedule, you started reaching out to connect with more people who are healthy people, et cetera, and the less credit that you give to the medicine you prescribe them for these positive changes, the less likely they are to quit medicine on you and complain of nocebo effects. So, we have to kind of swallow our pride here. And do not confuse compliance or treatment compliance with a therapeutic alliance. If a patient cannot disagree with you openly in the room, they will find ways to do it covertly by stopping their medicine, not picking up their prescription, forgetting the medicine, changing the dose. I think psychotherapists can really help us here as allies in coaching patients on how to assertively engage in their treatment. You can, I think that in a traditional medical model, there wasn't a lot of open disagreement with physicians. So we need to coach patients to ask questions. Why did you choose this particular medicine for me? What is the evidence behind choosing this treatment? Why did you choose this particular diagnosis? Did you consider other diagnoses? It's important to teach patients how to be advocates for themselves and not just passive receptacles of mental health treatment. This is a repeat slide from my previous presentation, but I like it. So I thought I would throw it in here again to review that. Now, our modern idea of a doctor-patient relationship in psychiatry is two expert co-investigators teaming up, where the doctor is the expertise in the medication selection and dosage and diagnosis and treatment plan, and the patient has their expertise in their symptoms. Whether they take the medicine or not is strictly their decision, their values, the side effects they experience, their goals. And we should not expect our patients to know how to be effective patients and know their role. And I feel like unfairly we complain a lot about patients, not being, outside their lane or not giving us the information we need when we haven't done enough teaching that patient what it is we need from them and how they become an effective patient. So, how are we addressing these nocebo effects? Leia here is working with Han. Han says, Seroquel is giving me insomnia. Leia notices that, well, it makes sense that you're afraid of being dependent on medication. He says, yeah, I like to do things solo. Let's talk about your fears and your goal to eventually be off of medication. So maybe Han, without a consistent caretaker, developed an avoidant attachment style. And Leia's recognizing how this is impacting his treatment alliance with his psychiatrist. Thus, she's encouraging overt instead of covert disagreement with the treatment plan here, so that they can address this nocebo effect together. And sometimes the patient is right. Always, we should ask ourselves in every situation, in what way is my patient actually right here? I'm quoting Dr. David Mintz. When the patient offers a criticism, the prescriber must preserve a place beyond defensiveness to seriously consider the question, how is the patient right? For prescribers to begin to see what has previously been out of their own awareness. So yes, there's a lot going on with our patients psychologically, and there's a lot going on with us psychologically, where we are really impacted by our history, by our experiences, by our upbringing, that we need to check into.
Curiosity you must have, ever mindful of your power over your patient, and humble of your knowledge you must be.
Yes. Mindful of our power and humble of our knowledge. So, that being said, it's important for patients to view us as having some expertise and some control, right? We want medical professionals that we feel like know what they're doing. So there's a balancing act between a patient's confidence in the expertise and guidance of the mental health professional and the patient's experience of self-agency and empowerment themselves. For example, we don't want to go too far over to the patient is in charge with, well, what medicine do you want, right? Instead, it's, here are some medication options. Here are the pros and cons of each choice. I give you these reasonable options, right? And the patient can choose. Because to an extent, it's important that patients view us as people of knowledge and power. So patient attitudes towards medication that predict a better outcome. Well, if they have high autonomy, they feel an internal locus of control. They have a sense that they are in charge of their treatment outcome. If they have high expectations that the treatment will benefit them, okay, that's the dopamine and the putamen there. If they view their depression not as strictly biological, but as more complex, and they experience empowerment and self-efficacy. Worst outcome, so sociotropy. Sociotropy means an orientation towards seeking help from and pleasing others. So rather, ironically, that leads to a worse outcome because they are less likely to disagree with their doctor and have that authentic dissent. Or patients who have low expectations of benefit, view their depression as strictly biological and outside of their control, and experience powerlessness and acquiescence to the wishes of others. So we can intentionally cultivate the stuff in the blue square here to enhance our medication effect, as both psychiatrists and psychotherapists can address this in session. Now, physician and psychotherapist attitudes towards medication that are helpful and unhelpful. So when we view mental illness as like a battle between a doctor and a disease where the patient is just the background, right? Or viewing the patient as a biological object on which we enact a chemical. First, instead of recognizing a patient as both subject and object. When we delude ourselves in believing that we precisely know how medications work, or our diagnoses are extremely clear-cut and always 100% accurate. Helpful attitudes in physicians, prescribers, and psychotherapists. So hope that the treatment will work, and that hope can be transmitted from us to patient. When we promote medication for health versus a focus on absence of symptoms, we think about achievement of developmental goals. We foster self-agency when we're attuned to the defensive and disempowering uses of medication, which we're going to talk more about. So when we prescribe a pill, this is actually a Concerta oral delivery system that I took from the Concerta website. When we prescribe a pill, it's more than methylphenidate in this pill. There's the power and control dynamics. There's expectation of harm or benefit. There's reenactment of relationships with early caregivers with the current prescriber. There's the symbolic meaning of the medicine. Does it symbolize caretaking from a nice doctor? Does it symbolize illness and deficit? Medications are both biologically and symbolically active. So, what about when the hyperdrive doesn't want to be fixed?
Do not underestimate the power of the sick role.
Indeed, do not underestimate the power of the sick role. Let's talk about our treatment-resistant patients, where the meaning of wellness is untenable to them.
As long as Misa remained depressed, Misa excused from unpleasant social obligations. Misa spouse is attentive to Misa needs, and Misa psychotherapist listens to Misa. Misa feel like Misa needs are finally being attended to. Misa voice is heard, and Misa treated like important person.
Indeed, Jar Jar Binks. So, this is usually a pretty subconscious process in our patients. And so I want us to have a lot of empathy and compassion for patients who are stuck in the sick role. Often, a patient's only access to support, connection, and loving care can be through a sick role. And in that way, it's actually sane and reasonable that they would want to remain in a sick role, not want to relinquish that. Until the family system is healthier and the patient has other avenues outside of their current family and friends to actually get support, they may remain unwell. And who can blame them? So think about, is an unhealthy family system or societal system orchestrating the persistence of an illness from the shadows? Is illness serving a function for the family? Because these patients aren't malicious layabouts wanting attention who are stuck in the sick role. Usually. They're usually not just lazy people who want to be excused from societal obligations. For some of these patients, for example, somaticizing patients, a physical ailment is an acceptable way to be ill, but not an emotional ailment. That's unacceptable. Or for some patients, particularly those who are disempowered by their system, they have no power in the family. Children, for example. The only way they have any power and control or say in what's going on is through an illness. These symptoms may represent the patient's best effort at managing an overwhelming emotion or communicating something that cannot be put into words, or for allowing a role in a family that would obviously be intolerable to the family if the patient weren't in the sick role. So think about, how does treatment resistance actually make sense in your patient's life? Qui-Gon Jinn wisely asked his patient, Jedi psychiatrist, what would you lose if you were suddenly well? And how can we meet that need in a healthier way? When the meaning of medication or the meaning of wellness is psychologically intolerable to a patient, treatment may fail. So patients, even while desiring to be rid of symptoms, may value them. We want to be on the lookout for subtle ways that symptoms will serve defensive functions for our patients. Now, let's talk about addressing treatment resistance. So there are patients who are resistant to allowing medication to have a positive effect, right? They're stuck in the sick role. They have nocebo effect. They're afraid of the medication. Usually our countertransference that we feel as treatment providers is frustration and helplessness. But there are also patients who are treatment resistant because of their medication. They are using their medications in counter-therapeutic ways. This can be explicit, like self-harm or recreational purposes, or to numb their feelings, or kind of covert, maybe to replace people or adaptive capacities. And the countertransference felt by the treatment professional is usually vague guilt or shame in these situations. Let's talk about when medications are overused and they replace healthy capacities. This makes sense because psychiatric patients have been betrayed by their feelings. They may learn to view all painful feelings as part of a disease process and may need our help, and their psychotherapist can really help with this too, to understand that painful feelings have a purpose as sources of information and also things that inspire us to grow. Palpatine says, "You have anxiety? Your meds must have stopped working." Whereas Yoda says, "Fear and disgust you have, so that leave your abusive husband for a new partner you can." When patients say their medicine has stopped working, medicines do stop working, of course, but also be curious about other possibilities. It's important for psychotherapists to ally with us in teaching patients the value of healthy, painful emotions, to ensure that medication is not used subversively to replace healthy capacities and miss out on growth opportunities when patients view painful feelings as disease processes. So resist treating healthy, painful emotions, unlike Vader. Jabba the Hutt. Starting to feel somewhat sad and lonely. All the women in my life are enslaved and don't really want to be with me. Opportunity for growth. Nah, I'm just going to up my dosage of medical marijuana. Missed opportunity for growth. So the way we address this with our patients is to emphasize not just symptom reduction, but achievement of developmental goals. Here's how Luke is doing it. When you take risperidone, Ray, you can distinguish what's real and not real. Then you can master the Force, hold down a fulfilling job, and find a healthy romantic partner who is not a Sith apprentice. So we're talking about not just taking away a psychiatric symptom of psychosis, but enabling achievement of a developmental process in life. We should be wary of countertransference prescribing. So when in countertransference prescribing, prescribed medications are managing the emotions of the prescriber, not the patient. How does that work? Yes, well, without humility regarding the limitations of our medications, sometimes the prescriber may feel the urge to pile on more and more medicine and keep finding the medicine that will fix the problem when the solution doesn't lie in a medicine bottle. When Vader prescribes a woman clonazepam because she just lost her husband, whose emotions is he treating? Her grief or his discomfort with her pain and need to do something to fix it? Discussing with a patient the treatment interfering meanings they hold in medication or wellness may or may not resolve treatment resistance, guys. But at least noticing it and being on the lookout for it can save clinicians from piling on medication after medication and feeling inadequate as physicians.
Absence of symptoms, absence of pain. Treatment is not. Achievement of health, resilience, adaptability, and capacity to work and love. It is.
Yeah. Treatment is not absence of symptoms or absence of pain. It is health, resilience, adaptability, and capacity to work and love. That's what we're aiming for. So let's talk about overusing medications to replace healthy relationships with people. Here, Han is talking about there's no one I can rely on like Xanax. Leia's asking him, who's the most supportive person in your life you can reach out to when you are feeling overwhelmed, though? Han says again, well, there's no one I can rely on like Xanax. And she notices, you're a lot more vulnerable when you reach for people instead of medication. Be wary that medications can be used in place of connection to people, and people can be extremely attached to their medications, especially patients who had neglectful or even abusive caregivers may use medication to manage their dysphoria and their painful feelings because it's a lot safer than relying on people who have betrayed them. And so when medications take over this kind of soothing parental function, it can be extremely triggering for these patients to taper those medications. We must be aware of this and very compassionate for them as we start the process of tapering them off of the medications and encouraging them to reach out to people instead. Let's talk about defensive use of diagnosis. Lando Calrissian tells us, I didn't betray all my friends because of my selfishness, narcissism, and greed. I was manic. It was bipolar disorder. My lithium level must be low. So, very convenient for Lando. Now, Lando's bad behavior is just a disease process and it's his prescriber's problem. So he's relieved of guilt and responsibility. We want to be aware of this. The defensive use of certain diagnoses in a disempowering way.
Your fault, disease, is not, but your responsibility, treatment, still is.
Thank you, Yoda. That's what we emphasize with these patients. Disease processes are not a patient's fault, and yet they're still responsible for treatment. This is one reason that patients, as you have noticed, may get really attached to a diagnosis like bipolar disorder, for example. And then because it just doesn't feel, saying depression, oh, it just doesn't feel severe enough to warrant how much of a negative impact I've had on everybody in my life. Sometimes parents may be extremely attached to a particular, let's say, bipolar disorder. Again, diagnosis for their child, to try to confirm that it is a very, very sick child, instead of to alleviate their felt inadequacy as a parent. Because ADHD, it just doesn't feel severe enough. And in these cases, I encourage not debating about correct diagnosis, but to explore, why is that diagnosis so important to that patient or that parent? And just say, hey, diagnostic categories are not clear cut, so we should remain curious. You think this, I think that, okay, let's stay curious and skeptical about your diagnosis. But notice when patients are very attached to a particular diagnosis and what that means for them. That's really good information for you. And then emphasize how the diagnosis informs them about themselves and can empower them to do more treatment. Now we're going to go over addressing meanings of medication in children. So, children are very focused on autonomy, competency, and identity. Did I really get an A on my test? Or was it in my medicine? Are these my feelings or my medicine? Reasonable questions. They are more vulnerable to nocebo effect because, again, they are in a position of low power and not a lot of choice. And they are more prone to expressing their dissent covertly since they have less control in their lives. They may want to stop medication to prove I can do it on my own, or see what I'm like without my medicine, the real me. It's very important to set yourself up for success when medicating children. Talk to kids about the role the medicine plays and the role they play in managing their feelings, behaviors, and relationships in a way that emphasizes self-agency and competency. So again, I have a weird metaphor for this. I use the example of a colorblind painter who finally gets these special glasses where suddenly he can see colors. And now his artwork is a lot more complex. However, he is no less deserving of praise or effort for his he is deserving of no less praise for his effort and ingenuity, even though he could not have done it without the glasses. Obi-Wan is talking to our young Leia here, and she says, okay, so even though I couldn't have done it without the medicine, I still get credit for doing it. And even though I'm on medicine, I still need to take responsibility for developing my emotion regulation skills. Yes, you will grow into a very wise woman someday, Leia. Pills are a powerful symbol of deficit, like we've talked about. And when the child is the one taking the pill, then the defect is perceived to be within the child. Leia correctly notes. So just because I'm the only one taking the medicine does not mean I'm the only one with problems or the only one who needs to change. Yes. Parents may experience a strong pull for a child to be on a medication to confirm that the issue is a sick child, rather than what they fear is that they are an inadequate parent. And conversely, parents may intensely resist a much needed medication for their child because they fear that their child being on medicine confirms that they are inadequate as parents. So it goes either way here, right? And medicines can be used to pinpoint the child as the problem to avoid having to address painful or shameful family dynamics. So discussing the meaning that medications have for parents is really important too. A true Jedi appreciates how an entire family system can contribute to maladaptive behaviors. Emperor Palpatine says, okay, little Billy's having anger outbursts. Let's just increase his medicine. Mara Jade, Jedi psychiatrist. Little Billy, maybe he does indeed need an increase in Adderall. But let's also explore what might be making him more angry. Billy reminds his mother of her abusive ex-husband, his father. Perhaps mother's favoritism towards his sister because of this and unconscious hostility towards him is playing a role. And we need to address that too. I'm going to end with the section on how psychotherapist allies can be most successful in aiding medication treatment. So, patients may feel safest revealing to their therapist, not the doctor prescribing the medicine, that they are not compliant with their medicine, abusing substances, overusing their medicine, or having side effects like I can't have an orgasm anymore on the medicine. So monitoring these things and reporting to us and keeping communication is very helpful. Also, psychotherapist allies can reframe taking medicine as a strength and a healthy behavior, thus decreasing shame, explore more about what taking medicine actually means to their patients, tell us if we miss something, teach patients to assertively disagree with their doctor, give us specific observations about how the patient is doing or which symptoms are impairing the patient the most. Like, I like to ask psychotherapists, your wish list, top 3 things you would want your client to gain from a new medicine. Very helpful for me. And just coordinating times is really hard. Like it's pretty like a act of God has to happen for like a therapist schedule and a doctor's schedule to match up. So if we can match up, that's awesome. And I do take the time to do that. But an exchange of detailed voicemails can also go a long way. When you give messages to a doctor, I would avoid jargon like manic or paranoid. Give specific behavioral evidence that supports your observation. For example, he's only sleeping 2 hours a night and is talking extremely rapidly and making some odd impulsive decisions. Then I'm more like, aha, I see what's going on, right? So good to back up your perspective with facts and observation. And be confident you have a different perspective that's worth sharing with the prescriber. Could you please not recommend specific medicines by name or specific categories of medicine, but do suggest specific symptoms that they should talk to us about targeting with medicine. For example, I would avoid you need a mood stabilizer or Lexapro is good. Xanax works really well. Because if a patient comes in and they're like, okay, well, I heard I need a mood stabilizer and that's not what I'm thinking they should have. It's kind of like you're between a rock and a hard place, right? You're like, well, I really wanted to prescribe them Zoloft for this, and this reason. They're thinking about getting pregnant soon and that has the most safety data, blah, 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 whatever is going on, right? But they got this Lexapro idea in their head. So if I prescribe the Zoloft, then it's like, well, who's right? Okay. And they're like, are you holding back on me on the ideal medicine? Or maybe should I not trust my other provider? It's just setting us up for badness. But it could be very helpful to say, ask Dr. Gruder what else can be done with medication for your anxiety. Please tell Dr. Greeter that you had periods of not sleeping for many nights in a row and have an increased sex drive. Coaching them about the symptoms that they really need to tell us about is super helpful. Finally, we are done, and I will take questions. If you want a copy of my PowerPoint slides or invites to future presentations, please put your email address in the chat, and I'm going to send it out later. I'm sending out a video recording, and I'll send out my PowerPoint slides. I'm going to stop the recording before I take questions so that you guys don't have to be recorded.